Hello, doctors. I'm Dr. Chris Rapoff of QME Continuing Education, and welcome to this week's presentation. Today, I'd like to discuss a rare anatomical abnormality known as Tarlov cyst. This cyst, which affects the nerve roots at the dorsal root ganglion, is often an incidental finding. However, it is classified as a clinical condition that requires treatment only when it becomes symptomatic. So in this discussion today, I aim to provide the key clinical insights and characteristics that are essential for us understanding this abnormality and what happens when it becomes symptomatic. So let's take a look. First, these are the following sources that I referenced when producing this presentation on Tarlov cyst. I encourage you to explore these references if you'd like to learn a more in-depth understanding of today's discussion. All right, as an introduction, the name Tarlov cyst comes from the person Isidor Max Tarlov. He was an American neurosurgeon who first described these cysts in 1938. Dr. Tarlov identified them while conducting autopsy studies and published his findings on their anatomy, nature, and the potential clinical significance of them. Now, a Tarlov cyst is actually referred to as a perineural cyst, and it's a fluid-filled sac located within the nerve root sheath at the dorsal root ganglion, most often in the sacral region of the spine, as you can see the diagram below. Now, these cysts are filled with cerebrospinal fluid and may actually compress nearby neural structures, potentially leading to the symptoms such as localized pain, neurological deficits, and dysfunction of bowel or bladder control. While many Tarlov cysts remain asymptomatic and require no intervention, symptomatic cysts are considered a clinical condition known as symptomatic Tarlov cyst syndrome. And this may necessitate specific management strategies. Now, these cysts are thought to form due to the following: a congenital factor, possibly due to a weakness in the connective tissue of the nerve root sheaths during fetal development, or acquired triggers, including a trauma, inflammation, or increased cerebrospinal fluid pressure that leads to a nerve root ballooning and cyst formation. And now, in symptomatic cases, these cysts may compress adjacent nerve structures, causing irritation, ischemia, or altered neural signaling. As I mentioned, this condition is rare, and it could be an insidious onset. It could be fetal development or due to trauma. So diagnostically, it's very challenging to arrive at a diagnosis of Tarlov cyst. And the clinical diagnosis of a symptomatic Tarlov cyst can be difficult. And the symptoms are lower back pain, possibly neurological deficit, or pelvic dysfunction. See, these symptoms are nonspecific and may overlap with many other conditions. Now, imaging studies do help differentiate Tarlov cysts, however. MRI, number one, is the gold standard for identifying these cysts. They show thin-walled, fluid-filled structures with the same signal intensity as CSF, or cerebrospinal fluid. A CT myelography also will confirm communication between the cysts and a subarachnoid space. And lastly, electromyography, or EMG, which may reveal some nerve root irritation or a dysfunction caused by a compression of a nerve. As I had mentioned, while asymptomatic cysts typically require no intervention, the symptomatic Tarlov cyst syndrome may necessitate specialized management. For example, some non-surgical options may include pain management. That would include medications such as analgesics, anti-inflammatory drugs, or anticonvulsants for the nerve pain, lifestyle modifications, avoiding activities that aggravate the symptoms alongside physical therapy, and potentially interventional procedures such as a CT-guided aspiration to reduce the cyst volume, and that's often paired with fibrin glue injection to seal the cyst closed. Now, surgical options can include a microsurgical technique, including fenestration. That's where a new opening is actually formed, and drainage that decompresses the nerve root. Also, cyst resection. It's reserved for the cases where the cyst wall needs removal to prevent reoccurrence. Take a look at the picture on the right. That's an example. And nerve root decompression is used to relieve pressure from the surrounding neural structures. Now, the prognosis for an individual who has a Tarlov cyst does depend on whether or not it's symptomatic or asymptomatic. So the prognosis depends largely on the symptom severity and the treatment approach. So asymptomatic cases are typically benign and require no intervention. However, in the symptomatic cases, early diagnosis and appropriate treatment can significantly improve outcomes, preventing the chronic pain or neurologic deficits. So in summary today, the Tarlov cyst actually represents a unique anatomical abnormality that may range from incidental findings to symptomatic cases that do require medical intervention. While most remain asymptomatic and benign, symptomatic Tarlov cyst syndrome can lead to significant pain, neurological deficits, and functional impairments. Advances in imaging and the treatment have really provided some valuable tools for the early diagnosis and management that ensures improved outcomes for the affected individuals. So by understanding their pathophysiology, their clinical significance, and the available therapies, we can better address the challenges that are posed by these rare yet impactful cysts and enhance the patient care in both conservative and surgical approaches. So, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you for taking the time to join me in today's presentation. I hope you enjoyed it, and I do look forward to sharing other interesting subjects as they relate to the workers' compensation system in the state of California in clinical significance and examinee significance as well. So until next time, thank you.